Welcome back, everyone. In the next two recordings, we're going to learn all about diabetes mellitus. The word diabetes comes from the Greek language meaning a siphon or to pass through. And the word mellitus is also from the Greek language meaning honey or sweet. So here we're talking about, glucose kind of passing through in the blood and into the urine. And that's how it's got its name, diabetes mellitus. In terms of what we're going to cover, we're going to talk all about the signs and symptoms of diabetes in general. Talk a little bit then about the pathophysiology of type 1 and type 2. We'll talk about the short-term complications of type 1 diabetes and type 2, and then follow that up with the long-term complications as well, and then finish up with just a little bit of information about metabolic syndrome. You've got your detailed learning objectives here for the first part of this recording. Now, diabetes mellitus is a chronic disorder which is characterized by high blood glucose levels. We're going to learn about type 1 and type 2 diabetes. Gestational diabetes also occurs on other forms of diabetes, but we're just going to stick with type 1 and type 2 for this subject. There are about 1.3 million people living with diagnosed diabetes. That's, statistics from 2021. It is likely that this number is much higher. It's just that these people haven't been diagnosed, so they're not included in the stats. Now, type 2 diabetes is far more common than type 1 diabetes, and the risk of developing type 2 is closely associated with central obesity, so increased abdominal fat. And the rapid rise in the prevalence of type 2 diabetes mirrors other nutrition-related lifestyle diseases, such as obesity, cardiovascular disease, and chronic renal disease as well. Now, in terms of the pathophysiology of diabetes, the abnormally high levels of glucose in the blood, being hyperglycemia, occurs because glucose can't be readily taken up into cells. So the insulin signaling mechanism is not working properly, and that leads to an insufficient number of GLUT4 transporters being inserted into the plasma membrane, and therefore insufficient glucose is taken up. Secondly, glycogen fails to store glucose in the liver, and that's partly because not enough glucose is being taken up by the liver to begin with. Now, when blood glucose levels exceed the renal threshold or the tubular maximum, the excess then is excreted by the kidney in urine, and that leads to glycosuria or glucose in urine. Okay, if you've got, lots of solutes, so glucose being present in the filtrate, that's going to lead to osmotic diuresis, where more water is drawn into the filtrate and therefore excreted. And this symptom is known as polyuria, which is frequent urination. If you're excreting large volumes of urine, that's going to decrease the blood volume, leading to hypovolemia. And in response to that, then water will leave cells to replace that lost water in the blood. And that leads to dehydration. Remember, if you're excreting large amounts of water in urine and the volume of the blood drops, that will also increase the solute concentration of the blood. And together this will stimulate the thirst sensation, and this leads to another symptom of diabetes being polydipsia, or excessive feeling of thirst. So the characteristic symptoms of diabetes are the 3 Ps. So polyphagia, meaning excessive hunger or increased appetite, particularly with type 1 diabetes. Polydipsia being that excessive thirst, and polyuria being that frequent urination. There are other symptoms, of course, common ones being fatigue and also itching. And the itching is due to a couple of reasons. Firstly, decreased circulation to the skin and decreased activity of sweat glands. So the skin becomes very dry and itchy. As well as that, with diabetes, there's an increased risk of fungal infections, and when that happens, then the skin becomes even more itchy. Diagnosis then is by measurement of high blood glucose levels, And a fasting blood glucose level of 7 millimoles per litre or more is diagnostic for diabetes. Glucose tolerance tests are also carried out to make the diagnosis. This is where somebody fasts overnight. Then they have a blood sample taken, and then they actually drink a drink with a set amount of glucose in it. And then over sort of 30-minute periods, over 2 hours, more blood samples are taken and analyzed to see how the body then is metabolizing that glucose. And we'll talk about that in more detail later on in this topic. So can you remember from last year how polyphagia, polydipsia, and polyuria occur? And if not, I'm going to take you through a little schematic that I've drawn on the next slide. So here we have a really badly drawn nephron. We've got our glomerulus, our afferent and efferent arterioles. We have the glomerular capsule, the first windy bit of the tubule system being the proximal convoluted tubule. We have the descending part of the loop of Henle and the ascending part of the loop of Henle, the distal convoluted tubule, and then the collecting duct. I've also drawn this little local sort of capillary just to show you what's going to happen. And I've also inserted these little pink boxes here into the proximal convoluted tubule, and these are sodium glucose symporter. So what happens here with these transporters are that sodium is reabsorbed from the filtrate back into the capillary and co-transports glucose at the same time. Okay, so no matter what the level of glucose is in the blood, it will get filtered and enter the glomerular capsule. So when somebody has normal glycemic control or normal amounts of glucose in the blood, all of that glucose enters the proximal convoluted tubule and it will encounter these sodium glucose transporters. When the blood glucose levels are normal, there are sufficient transporters to transport all of that glucose back into the blood. So to reabsorb it all from the filtrate back into the blood. I'll just show you another one there. So that by the time you reach the end of the proximal convoluted tubule, there shouldn't be any glucose left in the urine or the filtrate. So these distal parts then of the nephron won't have any glucose in the filtrate and therefore no glucose in the urine that's produced. However, in diabetes, there is excessively high blood glucose levels. So we'll just pop in a few more glucose molecules there, and they will all enter the proximal convoluted tubule as well, where they encounter the same transporters. Now, some of that glucose will be reabsorbed back into a capillary, but via saturation kinetics, there is just an insufficient number of these transporters to transport this very high level of glucose. So you kind of see this occurring in uncontrolled diabetes. So what happens then is these glucose molecules then start to appear in the more distal parts of the nephron where there are no sodium glucose transporters, and therefore will be present then in the urine, and that's a condition known as glycosuria. Okay, so as I mentioned, this is far more common in uncontrolled diabetes. Okay, now what I forgot to mention was in this descending part of the loop of Henle, it's structurally permeable to water. So water can leave the filtrate here. But what you have with excessively high glucose levels in the filtrate are these solutes then that are going to increase the osmotic pressure inside the filtrate and therefore prevent that water from leaving, and therefore high volumes of urine are going to be produced, and this is called polyuria, right? The polyuria, as I mentioned earlier, is going to reduce the blood volume, so the volume of the blood, and that's called hypovolemia. And the hypovolemia is going to increase the solute concentration of the blood, and that's going to lead to excessive thirst or polydipsia. The hypovolemia with that, higher solute concentration will also cause cellular dehydration as water moves from cells to replace that lost fluid in the blood. So overall, you can see in this uncontrolled diabetes scenario, you can see a situation how glycosuria leads to polyuria, hypovolemia, polydipsia, and cellular dehydration. So now looking at the differences between type 1 and type 2 diabetes, straight away you can see that the prevalence of type 2 diabetes is much, much higher than type 1, with type 2 making up, about 85% of all cases compared to 15% for type 1. Type 1 diabetes often has a juvenile onset, so before the age of 20. Type 2 diabetes tends to have a more mature onset, so often after the age of 35. But keep in mind that the demographics are kind of changing for type 2 diabetes, with many people getting diagnosed at a younger age. With type 1 diabetes, there usually is no involvement of obesity, whereas there is with type 2 diabetes. There is a far greater or stronger genetic link with type 2 diabetes over type 1 diabetes. So there's often a family history of people having, type 2 diabetes. With the type 1 diabetes, the most common cause of that is autoimmune destruction of the beta cells in the pancreas. So there may be some sort of genetic linking in terms of autoimmune conditions, but very often there's no other person in the family that or in the history of the family that has had diabetes. With type 1 diabetes, there is low or absent insulin levels by the time the diagnosis is made. Whereas with type 2 diabetes, depending on the stage of it, there's variable insulin levels. And early on in sort of the time course of type 2 diabetes, there can be very high insulin levels. And this is known as hyperinsulinemia. With type 1 diabetes, there's no insulin resistance at all. The problem is that there's just no insulin being produced by the pancreatic beta cells. The insulin receptors are perfectly normal, and the treatment involves exogenous insulin. As I mentioned, there's variable insulin levels with type 2 diabetes. Insulin resistance is present, so those cells become insensitive to the insulin signal, and there's either low or a low number of insulin receptors, or the insulin receptors are defective. And the treatment for type 2 diabetes can be in the form of, changes to the diet, changes to lifestyle, increasing exercise, decreasing smoking and alcohol. If that doesn't work, then these oral hypoglycemic agents, so these are tablets that are taken to lower blood glucose levels. And, if you think about early on in the stage of type 2 diabetes, if there's really high insulin levels, over time, that can cause the pancreas then to become damaged. Okay. The problem is that the actual cells are becoming insensitive or resistant to the insulin message. So early on, the pancreas keeps pumping out higher and higher levels of insulin, but the problem is at the cellular level and the receptor level. So the pancreas tends to get damaged over time, and when that happens, then some people with type 2 diabetes need to have exogenous insulin. Now, because of the fact that some people with type 2 diabetes have to take exogenous insulin, the terms insulin dependent diabetes for type 1 and non-insulin dependent diabetes for type 2, those terms are no longer used. And this is a table from the prescribed textbook, just detailing some of the stuff that I've spoken about on the previous slide, with a couple of extra things as well. I just want to draw your attention here to the onset of symptoms, which has sudden for type 1 compared to gradual for type 2. It used to be thought, that the onset of symptoms for type 1 was very sudden, but now we know that autoantibodies that are targeting the pancreatic beta cells are present a long time before these onset of symptoms. What else is here that we don't have? Complications are frequent to both type 1 and type 2. Ketoacidosis is a type of acidosis that is more common in type 1 and rare in type 2. Obviously, dietary modifications are mandatory for both types, and we've already been through the treatment options there.